So good morning, everybody. Thank you for inviting me to Coimbatore. It's a beautiful city. This morning, I woke up at 6. I went to the Murugan temple. Then I went to Isha, took some pictures, and came back. It was very nice coming back. The driver forgot the way, so we lost 40 minutes. But then we went to that idli place. What's the Anand? Yeah, we went there. It was very nice. So, Dr. John Roshan gave a talk before me, and he's been following this AFib patient for 17 years, and that's a long time. And he actually gave us a very good snapshot in how he has managed AFib over the years, and from 2005 to 2022. And we don't realize that every patient we see is at a certain point we get involved in their care. Right. In the meanwhile, they've had many life events, and for 17 years, they're also 17 years older. Right. In 2005, the patient he presented may have had a normal left atrial size. In 2022, the atrial size may be 5.56. And as the progression has happened from paroxysmal AFib to chronic AFib, the patient rate versus rhythm control, the strategy changes. So I think his point was very well taken that when we see a patient, we have to lay out expectations to these patients. So you've heard a few talks this morning, and I just want to add on to the approach we've taken to medicines and the approach we've taken. And my topic was, catheter ablation versus antiarrhythmic drugs. For us, I have a group of 5 electrophysiologists in Pittsburgh. And we over the years when we started doing cryoablation in 2014, and between 2007 when I finished fellowship to 2014 we were doing RF, and over time our AFib volumes have grown. In 2014 we used to have one day in the lab where we would do advanced cases, we would do AFib ablations, we would do 2 or 3 a day, and at that time the RFs took around 3 to 4 hours to do, so we would do two cases a day. Now fast forward 2022, in 2014 my group of 4 EPs, we did 100 AF cases, and now today, year to date, we did 700. So it's not that, so few things have happened. I think awareness in AFib has grown, and now people are coming and asking us for ablations, people are demanding more care, and the cardiologists who refer patients to us are also sending us the patients earlier. The reason all of this is happening is not because it's because technology has gotten better, but also the patients we're ablating are also feeling well. So by word of mouth, it spreads that AFib ablations work. So I'm going to talk a little bit about AFib. I'm going to try to stay within 20 minutes, but I think if I spend 5 more minutes, you wouldn't mind. And I'm going to give you some US data because I don't have Indian data, but I'm sure it's the same. A third of people, for us, at least hospital admissions, I think we are all aware in this room that atrial fibrillation makes up a big amount of hospital admissions. 30% of people get admitted for atrial fibrillation or some kind of arrhythmia, maybe atrial flutter, maybe SVT. The other third in cardiology are made up of heart failure, and then the other third are made up of ischemic heart disease. Now, with amyloid coming, I'm sure there'll be a third of amyloid patients too who will show up in the hospital. But the problem with atrial fibrillation is strokes and morbidity, and I don't have to go through that. But AFib prevalence is large and growing. This slide tells us that AFib has been growing more and more. There may be 2 reasons. One reason may be because we are screening more. We are looking for atrial fibrillation much harder than we did before, and that may be the case. But also I think people are seeing physicians, and we are also getting more aware that atrial fibrillation is a problem. 10 years, 15 years ago, in 2005, when Dr. Roshan's patient first came to see him, he was probably thinking of the AFFIRM trial. The AFFIRM trial basically said at that time, rate versus rhythm control is the same. You don't have to worry whether you rate or rhythm control. If the patient's symptomatic, you do put them in rhythm control. Then the AFFIRM 2 trial came out at the same time, suggesting that if you change the study and you keep them in rate versus rhythm, not as an intention to treat arm, but just basically as you want to keep them in sinus or you keep them in AFib, they realize that rhythm control is actually much better than rate control for morbidity and mortality. And that was key for us, that it also, before we thought AFib was a disease of morbidity, and we started realizing that it's a disease of mortality. And that's when thoughts started changing. This slide, I'm sure we presented in the previous talks. But atrial fibrillation begets atrial fibrillation. We know that. So the longer you're in AFib, the harder it's to get you out of atrial fibrillation. And the reason being, it leads to atrial fibrosis, atrial dilatation. Once you reach congestive heart failure, it gets very hard to manage atrial fibrillation. So how I do it, right? When Dr. And again, I go back to Dr. Roshan's talk, because I haven't seen patients for 17 years, and he documented it very well. But what I want to say to you is that his patient over 17 years went through 3 stages of atrial fibrillation. When he saw them initially, it was a paroxysmal. Then patients started getting cardioverted more often. It was more of a persistent AFib. And then for the last few years, it was a permanent AFib. So it's a beautiful time frame how we explained how the treatment changed over 17 years. So I do the same thing. When I see a patient in 2022 now, if I see a patient with atrial fibrillation, the first thing I look at is, number one, is what are their risk factors? Number two, what's the left atrial size? Even though left atrial size is not a marker, it's not one of, it's not part of the CHRS score for anticoagulation, but the left atrial size pretty much tells us what will be the success in maintaining sinus rhythm in the patient, right? The left atrial diameter is an easy marker if you do an echo. If the left atrial size is less than 4.5, patient has proximal atrial fibrillation, even permanent atrial fibrillation. If we ablate, they maintain sinus much longer, or if you put them on antiarrhythmics, they maintain sinus. Now, if you have somebody with the left atrial size of 5.5, then the success rate actually decreases. Dr. Roshan went through the drugs. The one drug that's not available in India is dofetilide, and we are very generous with dofetilide use. Actually, we use a lot of dofetilide in persistent AFib. Post-ablation, we use a lot of dofetilide, and dofetilide actually works much better than amiodarone. I mean, the success rate of all these drugs, which of all the antiarrhythmics, whether it be class 1, class E, combined, the success rate of antiarrhythmic drug treatment in a patient with atrial fibrillation is anywhere from 50 to 65%. In the amiodarone and dofetilide probably work in the 60% range, but others work in the 50-60% range. In what time frame? You can say within 5 years, the success rate is very less. Same thing with cardioversion, right? Success rate of cardioversion instantaneously is 100%, is 70 to 80%. For patients converting, but over long-term, success rate of cardioversion is only 50%. People will need some other adjunctive therapy. We've gone through this slide in the previous talk, but this study, I want to start off my talk with this study. It's called the STOP AFib trial. My friend Dr. Wasni presented it from the Cleveland Clinic. I think in September of 2021, it was released in New England Journal of Medicine. What this study basically said that in this study, they took people early on, when they were presented with AFib, they randomized themselves in 2 arms. One was atrial fibrillation ablation using cryo or drug therapy. So the data after 1 year, and this is only over 12 months, the data showed that people with ablation remained in sinus 75% of the time, and people with drugs remained in sinus 45% of the time. And your counter argument could be that atrial fibrillation ablation is not 100% successful. But if you look at patients over 10 to 15 years, even in our coronary artery disease stage, how many stents do they get in their lifetime, right? Each patient, the patient comes with an RCA lesion, gets an RCA stent. 5 years later, they get a stent in their circ. You still manage them with medications. Just because you put a stent in a person, you don't stop his Lipitor, you don't stop his beta blocker, you still continue. So just like coronary artery disease, think of atrial fibrillation or even congestive heart failure. These are all diseases which are lifetime. There's no cure. So you maintain and you control these disease states, and whether you use ablative therapy, you use stents, you use heart failure modulation therapy. In any of these 3 major disease states in cardiology, it's only a snapshot in time, and we act on it as we see. So I think the thought process that atrial fibrillation is something that you can ablate once and get 100% success, well, then I throw it back to my interventional colleagues. Have you given 100% success with a stent and stopped any medication? Which it's not true. So the same thing applies to atrial fibrillation, right? So, but this study is, I want to focus my talk on this study, and this came out last year. Based on this study, actually FDA, the FDA is the Food and Drug Administration in the US, actually changed the guideline last year and said cryoablation, not radiofrequency, cryoablation as an initial therapy was superior to drug therapy for prevention of atrial arrhythmias in patients with paroxysmal atrial fibrillation. And serious procedure-related adverse events were uncommon. I think in the last week, I went to a couple of cities, and we've done a few atrial fibrillation ablations. And these are the two big questions I've been asked: what are the side effects, right? And Dr. Roshan also, when he was talking about his patient and explaining to the side effects of an ablation, atrial fibrillation over the last 15 years, the ablation has progressed to so far that I only quote a less than 1% risk. And when we were talking to the other electrophysiologists room, we send our patients home in 4 to 6 hours after an ablation. And our complication rate has been very low. And during my 2 talks, I'll go through all of them too. But the key home, what I wanted to say is that right now, the guidelines for us is that we can offer cryoablation for atrial fibrillation and approximal atrial fibrillation as first line. We don't have to even wait till they fail medications. And rhythm control has actually become second line rather than first line, right? We can treat them with medications. So if I see a 55-year-old person who went to the hospital, got cardioverted, I mean, we don't have anybody by the name of Kanchana in the United States, but it'll probably be Samantha or something like that. But, whoever comes. If the 55-year-old person who has a normal left atrial size, the cardiologist saw them in the hospital, put them on, flecainide and NOACs and a beta blocker, and they come to us, and we get if there's a patient atrial fibrillation in the hospital, we automatically get a consult. So the cardiologist consult EP. The moment they see a patient AFib and they start the first line therapy, they consult EP for further management. Whether we cardiovert the patient, whether we suggest cardio, so we are consultants obviously too, and we are consultants to consultants. So we will actually in our first consult, we'll lay out the game plan for the patient. That, okay, for now, let's cardiovert the patient, keep them in sinus, send them home. We will talk to the patient about ablation as an outpatient. Or if the patient says, I want to get ablated, we'll talk to them. We'll say, okay, patient, we will set up the ablation in 4 to 6 weeks as an outpatient, and we bring the patient back, do primary ablation. If we see them in the office with atrial fibrillation, we'll set out a game plan over the next 3 to 5 years. And the main thing is to lay expectations of the patient that this is your success rate with ablation, this is your success rate with the drugs, this is how atrial fibrillation is going to pan out. And we tell them, the next 10, 15 years, if I look at the crystal ball, I can exactly tell you what your AFib is going to do. But the key factor is looking at left atrial size, right? Or if they have congestive, it's basically looking at the comorbidities. You can automatically predict how much you can maintain sinus rhythm. But if I tell you that, look, you're 55 years of age, if I can do an AFib ablation in you and keep you drug-free for 5 years, in my mind, it's a success. And so when you hit 60, then we will reevaluate your plan and we watch you every year. And we use a lot of implantable loop recorders, which we don't do here, to manage people with atrial fibrillation. Again, if you look at the data, out of 100, if I see 100 people with atrial fibrillation, 30% of people would be good candidates. 30% will say they're doing well on medications. 40% are asymptomatic. The word asymptomatic is very, it's very generic. We don't know. Just because you don't have symptoms doesn't mean you're having long-term side effects from atrial fibrillation. If your left atrial size is increasing, if your ejection fraction is dropping, if you have worsening heart failure, every time you come back to the hospital with AFib, you have heart failure, these are symptoms of atrial fibrillation. But the patient says, I feel fine, but so it's a very subjective, so we have to look at it more objective data. Asymptomatic 50-year-old gentleman with a left atrial size of 6, well, he's asymptomatic now, but in 5 years, you know what's going to happen. So you have to try to put them back into sinus rhythm. And right now, catheter ablation is a class 1A recommendation for us in people for atrial fibrillation and for paroxysmal. For persistence also, it's a class 1A recommendation. And the main goal of atrial fibrillation ablation, when we talk, the left atrium is huge. And so the goal is to do pulmonary isolation as the cornerstone of atrial fibrillation management currently. And we've gone through the mechanism of atrial fibrillation. There are a lot of theories that went on over the last few years, but right now we've all realized that atrial fibrillation comes from the pulmonary veins, and if we want to effectively manage people with atrial fibrillation and have any chance of maintaining sinus rhythm for long term, we have to isolate the pulmonary veins. And we can use radiofrequency ablation, or we can use cryopulmonary and isolation. These are the two modalities. We switched to cryopulmonary isolation in 2014 for pulmonary and isolation, just because my success rate was higher, and I'll show you data later on. So even now, and these are data in the U.S., that only 6% of people who need atrial fibrillation ablations get an AFib ablation. I'm sure the numbers are much lesser in India because I think the awareness to atrial fibrillation it's just been growing in the last 2 to 3 years, and then COVID came, and then everything kind of shut down. Now I think things are starting up a little more. Patients are coming, and we are realizing that atrial fibrillation has risks of morbidity and mortality. The procedure is very simple, and I'm not going to go into detail, but we go transeptal in these patients, go into the left atrium, and then we isolate the pulmonary veins. We can use mapping, or we can even do it fluoroscopically guided, or using transesophageal echocardiogram. But this is the data, and this data I'm showing you is from 2014. This is not new data. This has been around from the second International AFib Ablation Registry, that if you're paroxysmal, even in 2014, when ablation, maintenance of sinus rhythm is the mid 80%. This is just doing an ablation and getting them off antiarrhythmics. This data does not show if you're using radiofrequency or cryo. At that time, cryo was very minimal. This is just using radiofrequency ablation. Success rate of maintaining sinus after an ablation was 80% in paroxysmals, and persistence was in the 70s. And permanent atrial fibrillation, also we were getting low 70s ablation. And this slide I wanted to show you. If you say, look, these patients we are not going to maintain sinus rhythm 100%. If you treat a patient with antiarrhythmic drugs alone, that's the blue marker on the extreme left, success rate of maintaining sinus. And usually, how do you define success of maintaining sinus? It's over 36 months. If you maintain a patient in sinus rhythm, is defined as success of maintaining a person's sinus. It's only 40% if you use drug therapy. If you use antiarrhythmic drugs in a recurrent AF, people who are coming by the AF, so success rate is 40%. And as you start doing procedures, the success rate starts increasing. But if you look at the blue, the light blue, the last but one slide, it says if you do an ablation plus maintain them an antiarrhythmic in somebody who is a persistent or chronic atrial fibrillation, success rate of maintaining sinus is much higher. And it makes intuitive sense. As your stages of AFib worsen, antiarrhythmic drug usage is also we do use antiarrhythmic drugs post-ablation depending on what their comorbidities are. If you're diabetic, hypertensive, left atrial size is 5.4, even if I do an ablation, I'm not going to maintain you in sinus rhythm just by an ablation. I will use some adjunctive drug therapy. And like Dr. Gopi said, anticoagulation depends on CHAD score regardless of I maintain sinus rhythm or not. And this was the study which came out in 2010. Now fast forward 12 years. In 2010, and technology has gotten much better. Radiofrequency ablation of atrial fibrillation in 2010, when we were doing point by point radiofrequency ablation. At that time, we were still understanding atrial fibrillation. So our procedural success was lower. But despite that, in 2010, if you look at the graph, despite our shortcomings and technology shortcomings 12 years ago, we had Apple iPhone 2, we have iPhone 14 now, right? So technology has advanced greatly in 12 years. Even with an iPhone 2, we were achieving 80% success rate with radiofrequency ablation. And with medications over a year, success rate was much lower. And the safety, we've talked about safety with amiodarone, safety with flecainide. With flecainide, there was a comment that people are going to end up with pacemakers. With amiodarone, they're going to have multi-organ side effects. So over time, the safety profile of an ablation is much better than an antiarrhythmic drug. So then the question people ask me is, who's the most ideal patient for an atrial fibrillation? If we had an ideal world, then all of us would have been happy. Unfortunately, the world is not ideal, so the patients are also not ideal. So you can look at two ends of the spectrum, and the most optimal patient will be the gentleman we did yesterday, 50-year-old, 55-year-old gentleman with normal left atrial size, having proximal atrial fibrillation, highly symptomatic, with a normal ejection fraction, no history of other comorbidities. That would be the ideal patient. In a person like that, I would give them a 90% success rate of an ablation, but also I would give them a 90% success rate of getting off all medications also, right? So these conversations we've had with these patients will say, look, we can keep you in sinus, but we can also get you off medication, and I can give you a 90% success rate for 36 to 48 months. 5 years from now, who knows who we are, right? In 5 years, 4 or 5 years ago, my hair was all black. Now it's all white. So, 5 years is a long time in patient care. We can't expect the status quo is going to be maintained over 5 years. The less optimal patient obviously is going to be a person whose ejection fraction is 35 to 40%, who has recurrent heart failure, but every time he comes to hospital heart failure, he's in AFib with RVR, his left atrial size is longer, he's a little older, greater than 70, but it's all subjective. When I turned 50 this year, I thought everybody older than 50 was old. Now everybody in 70s are young. Now that I'm 50, 70 is young, So it's also very subjective. Just you cannot discount people in their 70s because it's that you can live with this. Now, in my mind, now 80 is old. But in 10 years, when I give this talk again, 80 will be young at that time too. So the older patient doesn't mean you have to discount them, because you have to look at the comorbidities. So the younger patients, we are saving them for morbidities and mortality. But the snapshot changes in the less ideal patient. We still take them for AFib ablation. But in this patient, I'll tell him, look, we'll do an ablation, but you may also have to stay on antiarrhythmics, and you will also have to stay in anticoagulation, but I'll decrease your comorbidities. So it's how it's every patient, you have to tailor medical needs to every patient depending on when and how you see them. And we talked about anticoagulation. And there are some variables in this which we can talk about which ones can be get off medications or not. So, and the thought process is the earlier, and the guidelines are changing. In 2015, when we did an AFib ablation, the guidelines said that you have to fail 2 antiarrhythmics. 2017 guidelines came out and said you have to fail 1 antiarrhythmic. Now 2022 guidelines say you don't even have to fail an antiarrhythmic, you can offer an AFib ablation to these patients firsthand. We were doing these ablations on people firsthand. In 2020, I would offer, if the patient came in on flecainide and he maintained sinus, I said, look, you can stay in sinus, stay on the medicines. When your AFib recurs, we'll do an ablation. Now when I see the patient, I said, do you want an ablation to get off the medicines? So even the way we approach the patient has changed. Now we don't even wait to offer them ablation because the guidelines now say it's first line. And majority of the AFib ablations, and this is in 2012, we targeted pulmonary in isolation. And, and the lady that Dr. Roshan presented at 2007, she had a AFib ablation. And when she had the AFib ablation, in 2007, we assume that the veins are isolated. But in 2007, if you take the patient back for a redo ablation, you will notice that things we did in 2007 don't apply in 2014. The left atrium has stretched. With left atrial stretch in 2007, we didn't have cryo, we did RF. There are going to be leaks. So so it may not have been unreasonable if the patient wanted. They could have gone back for a second ablation. And I'm noticing now, since I started AFib ablations in 2014, my redos have been coming back by 21, 22, 6 years. I've kept these people's sinus in 6 years. But they come back to see me now. Well, they're 10 pounds heavier. Now their diabetes is worse. Their high blood pressure is worse. Now they developed heart failure. Obviously, the AFib has come back because it's a disease state. It has come back. So we're taking them back for redo ablations. And when I look at it, if I take a patient back who had an RF ablation 10 years ago, 50% of the veins are connected. But if I take a patient, my cryo patient, not saying that I do a good job or not, but 95% of these veins are isolated. So the AFib is coming from other places. So then we offer them a posterior wall isolation when we go and ablate the left atrial posterior wall. But at this stage, the second time, I tell them, look, I'm not going to stop your antiarrhythmics. You'll probably stay on antiarrhythmics. We also take them for a third ablation, right? For third ablation, we isolate the vein of Marshall. We isolate the RASVC. We do more lesions. And then the fourth time, we do send them for hybrid therapy. It's a convergent procedure where the surgeons do epicardially. So there are a lot of things we can offer the atrial fibrillation patients as long as they're symptomatic, right? So in 2012, and when I'm saying at the point RF energy versus cryo, where the 2 standard ablation systems were used for catheter ablation, and this is going back 10 years. And I've been doing cryo for 2014. I've done probably over 1,000 cases, but it's a very simple system. It's basically you freeze the left veins. I was making fun yesterday when I grew up in Visakhapatnam, and there was something called the soda goli bottle. So that's basically what it is. Putting a round peg into a round hole. It's just use the goli to plug the pulmonary vein, and you give pressure and it occludes. So that's why I call the AFib ablation a soda goli, right? This goli soda. So that's what it is. But it's a very easy procedure. Yesterday, the procedure we did with Dr. Jairaj, we were done in 1 hour. Each procedure was done in 1 hour. Left atrial dwell time 1 hour. We saw the sinus rhythm convert. And it's a balloon that gives liquid nitrogen. It's a very safe energy delivery system. Because of that, complication rates are much lower, but I'll talk about that in my second talk. What we usually do is we go transeptal, put the vein, we shoot a venogram, show that the vein is occluded, and then we ablate for between 3 to 4 minutes each vein. So technically, you should be done very quickly. And we go to each vein, we inflate, and then we ablate, and we assess for pulmonary isolation. And most people have 4 pulmonary veins. Some people will have 3, some people will have 5, but 90% of people will have 4 pulmonary veins. It's a pretty straightforward procedure. So the stop AF, so I started with the stop AF, and then I want to stop this talk with the stop AF. Basically, the AF, stop AF for the study which started at the Cleveland Clinic. They took 245 patients who had proximal atrial fibrillation. They put them in the AF drug group or the cryo group. And they looked at follow-up with Holter and clinical follow-up. And this was the data which showed up in STOP AF. This data basically, it came out in the New England Journal, like I said, and it said you could use atrial fibrillation ablation first line, and the CMS went ahead and changed the guidelines that atrial fibrillation ablation is offered as first-line therapy. Then if you look at if the AFib came back, are the pulmonary veins isolated? So when you looked at all these, some people got EP studies post-ablation. This was not part of the STOP AF study. Even prior to that, Doug Packer's study 10 years said isolation of pulmonary veins is almost 98 to 99% with the cryoablation technique. So at this time, when this paper came out in 2013, my group switched to cryoablation as primary for pulmonary vein isolation. So 70% of people, I think, in the United States use cryo for pulmonary vein isolation. The other parts of the left atrium, they can use any other therapeutic modality, but pulmonary vein isolation, cryoablation of pulmonary vein isolation has become cornerstone for AFib ablations. And success rate, and this again, like I said, going back to 2013, success rate is 70%. And this was with the first generation balloon. Now we have the second generation balloon, and the success rate is almost in the 80% range. And if you look at the meta-analysis, all studies pretty much is ending up in the same 75 to 85% rate in people who have an AFib ablation. And then if you look at this, there are multiple single-center studies which looked at freedom from atrial fibrillation, and they're all in the high 80s or 90s stages for maintaining sinus rhythm in people with proximal atrial fibrillation. And if you look at takedown single-center studies, what is the freedom of getting you off antiarrhythmics? Getting you off antiarrhythmics and maintaining sinus rhythm also in the 80% range. If everything in life was 100%, we wouldn't be in business here today. We wouldn't be physicians, unfortunately. Our patients are also very sick. And so I give them 80 to 90%. There's one question which I'll talk in my next talk about phrenic nerve pacing, but the incidence of phrenic nerve palsy in people is usually around 1 to 2%, which resolves 10 months post-ablation. So cryo versus radiofrequency ablation, so the question is, what modality do you choose to ablate? Would you use cryo or would you use radiofrequency? I've used cryo, but not because of personal preference. It's because of the data. When you do a cryoablation, the lesion set is very organized. With radiofrequency, you do point by point, and this is a balloon-based ablation. So you take the balloon, you inflate it in the pulmonary veins, you get a nice circumferential ablation. With point by point, even however good you are, you're going to miss a certain spot, and you may have to go back because it creates re-entries. So, the STOP AFib also, I talked to studies that they did a post-approval study for people said, okay, well, STOP AF, early AF, STOP AF, all these studies happen in research. But if you look at this registry, which looks at real-world data, success rate actually was much better in the post-approval studies also. Then Fire and Ice came out a couple of years in 2016, and it basically said if you use cryoablation is actually, the ablation, maintaining the sinus was non-inferior. The procedure time actually got much faster. If you look here, the dwell time was 90 minutes 6 years ago. Right now, our left atrial dwell time is around 45 minutes to an hour. So we've almost shaved off half. Our procedure time from 2 hours in 2022 is down to an hour. Our fluoroscopy times are much significantly. I use minimal fluoroscopy. There are some doctors who do 0. My fluoroscopy time for pulmonary in isolation alone is usually between 1 to 1.5 minutes of fluoro time. And if you look at the cryo group, people who got cryoablation versus radiofrequency ablation had less. A third of people had less repeat ablations, but the very fact that we did not create any re-entries. We gave a circumferential lesion, the atrial fibrillation went away, and the annoying part of recurrent atrial tachycardias, left side atrial flutters, we haven't seen that in years. And 50% less cardioversions people of the cryoablation group was the radiofrequency group. So again, going back to Dr. Roshan's patient, if the AFib started recurring in 2014, 2015, 5 to 6 years after AFib and the medicine stopped failing, at that point we could have offered a cryoablation. We would have maintained her in sinus for another 2-3 years. Eventually she would have ended up with a pacemaker, right? I mean, eventually everything that happened in this patient for 17 years, she would have gotten a pacemaker, but we would have maintained sinus rhythm for much longer in this lady. Quality of life is, I think other than, nobody cares about physicians' quality of life, but patient quality of life is very important. Every study has been done on the mental and the physical part of quality of life. There are some studies also coming out that people with permanent AFib have more dementia. They have more, they have more chance of having heart failure. They have, they have more short of breath. So if you look at the quality of life questionnaires, they're actually people who have maintained sinus rhythm have done much better, regardless of if you do radiofrequency ablation or cryoablation. So the Fire and Ice basically concluded that quality of life was equal whichever modality used, but cryo was and this was 6 years ago with the first and second generation, but cryo was tending to be more superior to radiofrequency ablation at that time. And that's the time when we switched from radiofrequency ablation to cryo, when that data had come out in 2013. So from 2014 on, as me and my group of 5 we only do cryopulmonary isolation for pulmonary veins. Like I said, the other modalities we can use other therapy. And then I'll stop again with the slide I showed you first with the STOP AF study, which came out last year, basically showing that ablation, now primary ablations, we are offering primary ablations to the patients, and patients don't want to take long-term anticoagulation. The data itself speaks for it, right? I have a 75% chance in maintaining sinus rhythm in somebody with an early ablation, and 45% chance of maintaining sinus with drug therapy. And this is in people who came early. I mean, this is not even in people who came 5 or 6 years down the road for atrial fibrillation. So I'm going to stop here. I'll entertain any questions you have. Thank you very much.